Good morning, everyone, and welcome again to our CME meeting. It's the last Friday of the month. So happy October and happy Breast Cancer Awareness Month to everyone. And I see we're having good afternoon from Turkey. So thank you to all our colleagues from all over the world that I see are joining us today for this morning's meeting. So it's indeed a very special meeting this morning. And I am going to introduce our chair for today. Our chair for today is a very special person, someone I've known throughout my entire career, and I've grown up together with him, Dr. Shani Knowles. Dr. Shani Knowles is no stranger to anyone on this group. And Dr. Shani Knowles is a consultant pediatric surgeon and a consultant at the Princess Margaret Hospital and at Doctors Hospital in the Bahamas. Dr. Shani Knowles is going to chair this morning's meeting and introduce this morning's very special guest. Thank you, Dr. Knowles.
Good morning, everybody from around the world, all friends who'll be on other meetings. It's a pleasure to present one of my mentors and someone who I trained with for different procedures. I mean, I could spend the entire hour talking about his accomplishments. He's arguably one of the top pediatric surgeons to ever grace this earth. Mark Levitt was born in Allentown, Pennsylvania. He did his bachelor's at the University of Pennsylvania. He went to med school at, I miss it, he'll put that in, but he did his residency at Mount Sinai, his fellowship at University of Buffalo. He's a disciple of Alberto Pena, whom he met as a medical student. And together they developed colorectal and pelvic reconstruction. Okay, now I get to the heavy parts. So Mark has done more than 300 peer-reviewed papers. He has written 100 book chapters, and he's written 4 books. He's treated children from 50 states in the US and almost 80 countries. As a matter of fact, I'm dressed in God because we have a patient with a cloacal exstrophy that we're going to do a vesicostomy and a colostomy on, and Mark has been influential in that with that patient. I could go on, but I just want to present my friend, my mentor, the guy who trained me, PSOPs, pull-throughs, who my senior fellow, Richard Wood, he mentored him into actually becoming the director at Nationwide. I present to you Mark Levitt.
Thank you, good friend. Good to see you. We just saw you here in Washington, D.C. a couple of weeks ago. We missed you already. And I'm thrilled to join your group. Folks from all over the world. Looks like we have 96 participants. And thank you for that kind introduction. I was asked today to talk about a subject that's near and dear to my heart that most would not consider a surgical problem. But what I want to try to convey is the challenges of constipation and talk a little bit about fecal incontinence in children, which is an incredibly difficult problem that pediatricians, gastroenterologists, and surgeons all play a role in. So what I want to try to do, hopefully successfully, is share my screen. And let's see if I can do that. And please let me know.
Yes.
If you can see my PowerPoint.
Yes, looking good.
Okay. So the title of today's talk is Constipation's Morbidity, which include things like poor appetite, abdominal pain, and soiling. And I want to give some guidance for both the pediatrician and the specialty pediatrician of gastroenterologists and the surgeon. So I'll hopefully have something for all of those members in the audience. All right. I'm not sure if in the various parts of the world, this is a commonly read book. Is it? Shani, did you read this book to your kids by chance?
No, I didn't, but I'm sure some of my colleagues would
So
have.
this is a very important book. I highly recommend it. And I have taken this book on with a lot of passion, recognizing that the ability to stool should not be taken for granted. And amazingly, it often is. And for all the pediatric surgeons on the call, I can assure you that we have all had the experience where we take care of a family whose baby was just born with an anorectal malformation. And they say to us, we never even heard that that was something that could go wrong. We've heard about cardiac defects, we've heard about cystic fibrosis, but we never knew there could be a problem with passing of stool. We took that for granted. And don't forget that what we need to work on is book 2, which is this book, which of course affects the problem of stooling affects many, many children. In fact, you may not be aware, 10% of all visits to a pediatrician's office involve constipation. And if you sampled all patients, children who have presented to the emergency room with abdominal pain, the #1 cause is not appendicitis, it's constipation. So we have a big challenge to try to solve this. I found this really funny. This was a 4th grade student's answer to a science quiz, and I suspect this individual is a future pediatric colorectal surgeon. All right, let's begin by understanding the process whereby we are continent, something you perhaps haven't thought much about, but there are essentially 3 main components. One is the sphincters, and we have a very complex sphincter system. We have an internal anal sphincter, which provides us with tone throughout the day. And when there is distension of the rectum with stool present in the rectal vault, we then have the power to add additional holding capacity to the anus by adding the external sphincter, which we control, to hold in the stool and then find a bathroom and then release the stool. At the same moment that we overcome any ability of our stool to pass with our external sphincters, the internal sphincters relax. That's called the RARE, recto-anal inhibitory reflex. So our internal sphincters, which provide tone all day long so we don't leak, relax at the appropriate time when they are functioning normally. And then our external sphincters, which we have voluntary control of, hold the stool in until the appropriate time to pass the stool. Well, as you can imagine, there are many patients with various dysfunction at the sphincter level. The other factor is the anal canal sensation. We have an anal canal, which is exquisitely sensitive. It's as sensitive as our fingertips. So just like I could place a coin in your fingers with your eyes closed, and you could tell what type of coin it is in the various denominations, depending on what country you're in. Likewise, the anal canal can detect the difference between solid, liquid, and gas. So we need that capacity to know whether we can allow gas to pass or whether we need to hold in tighter because the stools seem liquidy, or when it is the appropriate time to release those stools. And then, of course, the important variable of motility. Does the stool move quickly or slowly? So if you have diarrhea, it moves very quickly. And thank goodness we have good sphincters and an anal canal that can hold it in. Most of the kids that we're going to be talking about today have slow moving motility. The colon doesn't move well for a variety of reasons. Okay, so our first key step I find very valuable is a contrast study. And this is an image that many of you have seen in which the rectosigmoid is quite large, but you can see that just above the middle portion of the sigmoid, the caliber of the colon looks much more normal. And you can actually see little haustral markings, those little indentations. This is a poor man's way of doing a motility test. So from this image that the colon working well, the sigmoid where the peristaltic waves seem to stop, and the rectosigmoid is dilated. And this is the anatomy that many of our patients are dealing with. I suspect they were not born this way. They developed this distension due to poor motility in that segment or poor sphincters distally, meaning a functional obstruction, or both. All right, so a typical patient, let's say a 10-year-old child who has had constipation since being started on solid foods when he was about 1 year of age. What are some concerning symptoms? What laxatives should be started? Let's talk about this a little bit. So constipation that is symptomatic. We have patients that won't eat. They have early satiety. We have patients that get crampy abdominal pain related to their inability to pass stool. We have patients that are distended. We have patients that have such a level of impaction that they soil. And the stools can be so hard that they cause small tears in the anus. That's called a fissure. So all of these are symptoms and signs that you might find in your pediatric office or your gastroenterology office or in the emergency room or as a surgeon being called on to help such a patient. Well, what laxatives should be started? So the first line of therapy obviously is medical. And I'm very focused on the medical part because I see many patients that someone thinks needs surgery and in fact just needs better medical management. In fact, if you think about all comers, if you take 1,000 patients that have constipation, about 900 of them should be easily managed by their pediatrician with some dietary changes or some laxative therapy, which I will get into. Leaving 100 patients. 100 patients might need a referral to a gastroenterologist who might ramp up the amount of laxatives that are given and may make the patient better, or may change the diet, or do something that the pediatrician had not figured out. And they should be able to handle about 90 of those patients with no additional referrals, leaving 10 out of 1,000 that they cannot solve. I see those 10 because someone says, we need a surgeon. And I can tell you, of those 10, only one needs a surgical intervention. The other 9 usually just need a more aggressive laxative treatment or different medical treatments, which I'm going to explain, which could be something like a rectal enema, or could be something a little more surgical, like a Botox injection of the anal canal. And then even a little more surgical would be an ability to flush the colon from the top down, namely through a antegrade option like a Malone. But let's go back to the 900 patients that the pediatrician manages. Laxatives. Well, I can tell you in most cases, the change of the diet to more of a laxative diet, promoting certain types of fiber, increasing certain types of fruits and vegetables in the diet, do the trick. Some need medical therapy. A very common medication that's used is something like Glycolax. And I will tell you that works for the easy to solve patient. But just softening the stool is not usually the solution. The stool needs to be provoked to come out. It needs a provocative, i.e. a stimulant medication. And for that, we only have 2, Senna and bisacodyl. Those provoke the stool to come out. So my preference is to use one of those. We use a lot of Senna. First step, though, is you must get an empty colon, because if you give that patient Senna, they will get severe cramps. So you need to make sure that the colon is empty, and that's a patient that needs a clean out. And for that, a Miralax prep, about 8 capsules of Miralax and 64 ounces of some liquid like Gatorade or some electrolyte solution of some sort, really does the trick, cleans the patient out, and now you start with a clean slate and can provoke the stools to empty with the help of a stimulant laxative. And a stimulant laxative at the appropriate dose. What is the appropriate dose? Whatever it takes to empty the colon. And if you reach a high dose and the colon is not emptying, or if that high dose causes significant symptoms, now we need to talk about a surgical option. Okay, so medical management could be all of these types of laxatives that you see here, and there's literally dozens of products. Again, my preference is something with senna or something with bisacodyl. And I would also consider a rectal enema a medical management. There are some patients that, for behavioral reasons, they cannot take their medication or won't know when they need to go to the bathroom. And for them, a routine mechanical emptying via a rectal enema is very good medical management. However, of course, the rectal route is often not tolerated. And then another version of what I consider medical management would be an antegrade option, which obviously requires a surgical procedure. To speak briefly about that, for example, if you had a child that was having poor nutrition and was not gaining weight, and you asked a surgeon to place a gastrostomy tube, in my view, that gastrostomy tube is just an adjunct to better medical therapy. You are able to maximize the patient's nutrition because you have a surgical route to the enteral system. Just like that, we have a route to the colon by creating antegrade access. And I have some pictures of that to show you. Well, diet is actually quite relevant. This is a funny slide of a patient perhaps that received too much fiber, but water-soluble fiber or water-insoluble fiber. Well, water-insoluble fiber makes you go. Water-soluble fiber absorbs the water and thickens the stool. So be very cognizant what type of fiber you are giving with what goal you're trying to achieve in the consistency of the stool. Many different types of foods have effect, and there are nice lists available of what foods are stool provoking and what foods slow things down. Well, what do we mean by medical management that is failing? The patient has failure to thrive. The laxatives cause intolerable symptoms, mainly cramping. The laxatives do not empty the colon. They don't work. The patient has persistent soiling, accidents, continued abdominal pain. And then the ultimate failure of medical management is both retrograde and antegrade enemas don't work. And then we have to start talking about whether the colon may need some surgery itself with a segment of it removed. All right, a question that comes up frequently is, first of all, do we need a pediatric GI referral? And does the patient have Hirschsprung's disease? We all know about that. We obviously don't want to miss a case of Hirschsprung's disease, but you should know that the vast majority of patients with Hirschsprung's disease are diagnosed in the first year of life with pretty dramatic symptoms of distension or even enterocolitis. It's pretty rare that you get an older child Hirschsprung's, but it happens enough that we need to be aware of it and we need to evaluate for it. So I think a key first step is to obtain a contrast study. The contrast study you see here, and they all come with an initial scout film. And this scout film shows a lot of impaction in the rectum area. And similar to the other image I showed you, you see these beautiful peristaltic waves. The ridges are haustra. And of course, the rectum appears quite inert and impacted. Well, this does not look like Hirschsprung's disease. This looks like bad constipation. But we need to evaluate for Hirschsprung's disease as well. And the best way to do that is an anorectal manometry. And of course, the gold standard is to do a rectal biopsy. But most such patients with constipation just need a clean out and then more aggressive laxative therapy, as I have discussed. All right, so our first question, are the sphincters the problem? And can we rule out Hirschsprung's by evaluating the sphincters? Remember, your ability to stool is essentially dependent on what happens at the very bottom, How are the sphincters functioning? Are they relaxing at the appropriate time? Are they too tight? And then how is the colon? Is the colon flowing well, or is it extremely slow? Some patients have problem with sphincters and sphincters alone. Some patients have problem with the colon and the colon alone, and some patients have problems in both areas. There's a bit of chaos out there as far as how these patients are treated. I frequently will see a patient who's treated with an enormous amount of laxatives, and in fact, their sphincters were the problem, and all they needed was one injection of botulinum toxin, and their constipation has gone away. They don't need those laxatives anymore. So a methodical approach to the patient with severe constipation, intractable constipation that is not responsive to typical therapy, is what I'm about to outline. First step we do is what's called an anorectal manometry, whereby we put this thin probe that has an inflatable balloon through the anal canal and we distend it. And we can learn a lot from this information. Ideally, this is done awake in a cooperative patient. Occasionally, we do this in the operating room with some mild sedation. And we do this as a combination. A very nice collaboration exists here between GI and surgery, where such a patient comes to the operating room. They are remaining awake with the anesthesiologist on standby. We do the anorectal manometry, and based on our findings, we decide what needs to be done. So for example, the anorectal manometry might show that the internal sphincter fails to relax upon distension of the rectum. It's supposed to relax. That's called an intact rare. However, if the rare rectoanal inhibitory reflex does not happen, if the internal sphincter in fact tightens instead of relaxing, that could be a sign of Hirschsprung's disease. And then we go ahead and do a rectal biopsy right then and there. If it's not Hirschsprung's disease, the other thing that could fail to relax the internal sphincter is something called internal sphincter achalasia. The treatment for that is Botox. So we go ahead and give the Botox. So our routine here is to do an anorectal manometry with possible biopsy with possible Botox. Also, I cannot emphasize this enough, that patient needs a rectal exam. Be aware that some patients have an anal stenosis, and the only way you're going to know that that's true is by doing a digital exam and feeling that there's a supple anal canal with no stricture, no stenotic ring around it. We just found one of these this week in a patient who had been suffering with constipation for 5 years, and no one had done a proper rectal exam to find that stricture. And now the kid will be solved with a very minor surgical procedure. So the anorectal manometry is done. We define whether there's a sphincter problem. The external sphincter, the voluntary sphincter, can also be a problem. It can be too tight. High resting pressure, the treatment for that is also Botox. And this anorectal manometry also tells us about the pelvic floor and tells us, does the pelvic floor have the capacity to relax? And the treatment for that is biofeedback. So in about 15 minutes, we get an incredible amount of information. We can improve our diagnostic ability if we do a biopsy. We can actually treat the patient if we show that they need Botox. All right, let's move on. Maybe the colon is the problem. Well, how do we figure that out? Well, we need to assess the colonic motility. How does the colon flow? What we do here, you see depicted in this image, we use colonic manometry, and it's like an EKG of the colon. And you see here these waves of contraction, the HAPCs, high amplitude propagating contractions of the colon, and they seem to do well until the flat line area you see at the bottom, that is the sigmoid. So in this particular patient, the colon works well, except the sigmoid is not working. I would call that a segmental dysmotility, and maybe that segment might need to be resected by a surgeon. There are other ways to assess colonic motility if you don't have colonic manometry available to you. Sitzmark study, where you put these little metallic beads, You have the patient swallow them, and you get a follow-up X-ray, and you see, have the beads passed through, or are they caught up in a certain part of the colon? And nuclear medicine can do a colonic scintigraphy, where they follow the flow of the colon, also a very effective way to determine the colonic motility. All right, so the question is, can we facilitate emptying of the colon? What are the treatments if laxatives are not working? And I've alluded to this several times. Here are some pictures of an antegrade option. You can put a tube, or you can allow for a catheterizable channel. You see the patient on the right's belly button is quite normal appearing, but there is a tiny little hole in the umbilical fold through which a 10 French catheter can be inserted. In the girl in the picture in the circle has a little tiny device that looks like a G-tube, but it's actually in her cecum. And this is all a Malone, i.e. appendicostomy, or a cecostomy. So you have a surgeon provide this access, and then the colon can be flushed from top down with saline plus an additive such as glycerin, and we provoke a controlled bowel movement once a day. And the beautiful thing about this is the child stools in response to the flush and then does not stool again for the next 24 hours. So for patients who have no capacity for continence, like those with, let's say, spina bifida, or a sacral tumor, presacral mass tumor, or an anorectal malformation patient with poor sphincters, we can overcome this by promoting a bowel movement that we have mechanically induced once per day, and the patient is clean the next 24 hours. On occasion, a patient needs a segment of their colon removed if the colon is not responsive to this antegrade flush. And here you see an artistic diagram of this enormous sigmoid that is being resected. In panel 2, the sigmoid has now been removed, and we keep the access for the antegrade flush. And over time, amazingly, some of these colons then start to work normally once the very dilated segment has been removed. All right, well, I like this picture very much because it tells the story about how difficult it is to provide care to colorectal patients. I think most people think that it's easy, but in fact, it is a very heavy lift. As you see my dad here with his proud moment catching a 40-pound redfish. It's a heavy lift, requires an intense amount of work, a lot of tinkering with the patient, and a lot of help from various colleagues. In this patient group, obviously you need collaboration between pediatrics, peds GI, and colorectal. And I can't say enough about the vital importance of nursing in the care of these patients, because they are so well aware of the treatments and the tinkering that's required and the amount of family engagement that we would not be nearly as successful without their collaboration. So if you're going to take this on as a project in your various hospitals, please, for the surgeons, find yourself a nurse that helps you get through the day with the challenge of these patients. A little bit about what we're trying to accomplish here. You may recognize this image from Washington, D.C., but I show this in a very specific, for a very specific reason. I want you to conceptualize what happened when each of these three architectural entities were designed. My suspicion is that a bunch of people got in a room, talked about how the bridge ought to look, decided on a schedule, when should the cement people come, when should the steel people come, when do you install the lights, etc. Unfortunately, in medicine, we don't do this. We take care of the problem in front of us, and we don't think a lot about all the other fields of medicine that might need to be involved with the care of that patient, meaning the collaborative process that is so well done in architectural design is not so well done for the complex patient in our medical fields. For example, a urologist might manage a urologic problem in an anorectal malformation patient, and they don't realize that, in fact, had the colon been a better emptying colon, maybe the urologic problem would have been less problematic. We've seen patients in whom the colon emptying better resolves their vesicoureteral reflux. Such a patient didn't necessarily need a ureteral reimplantation, if only for better colon treatment. So I would recommend for complex patients in all fields, cardiac, cystic fibrosis, et cetera, that the collaborative model be employed. In our world, the collaborative model involves these specialists, which I can, which you can see here on the list, all working well together surrounding the patient. And if you can accomplish that, you can actually get to the equation of 1 + 1 = 3. And we have a unique collaboration here between GI motility, colorectal, gynecology, and urology that formulates this division. And I hope you enjoy this nice cartoon of the GI tract, and I'd be happy to take your questions. If anyone is still even there. You never
Yes,
know with these.
we are all still here, Dr. Mark Levitt. Thank you very much for that really excellent presentation. Dr. Knowles, are you still with us?
You know, you never know with these presentations whether anyone's actually listening, but supposedly there are 199 participants. We need one more.
Yes, so we did actually go over to 202 during the
Ah.
presentation.
Okay.
And so if there are any questions, you can post it in the chat. You know, thank you very much for the nice presentation. And just so that everyone knows, your mics are open. So if you would like to open your mic and ask a question, you can go ahead. And I see Dr. Knowles is back with us. Dr. Knowles?
Yeah, my internet went.
Okay.
So I'm on my phone now. Good old internet, good old alive. Main Cable, Bahamas. Okay, so yeah, any questions?
Looks like Fareed has a question.
Good morning
Okay.
to my colleague. I am a pediatric surgeon from Libya. I would like to thank for this nice presentation. It was an overview, quickly overview. The points that maybe we, as a surgeon, we need to know from the contrast enema, what we are looking precisely for the type of colon, hypo or hypermotor. This is one. Next one about the fecal incontinence. Is it a true fecal incontinence due to previous problems, as you mentioned, Hirschsprung damaged in a canal or other pathology associated, or the spectrum of anorectal malformation, those with poor outcomes, and the fecal pseudo incontinence.
So
Yeah.
let me handle those first. First of all, I think the contrast study is a very helpful adjunct. It tells you a lot about the motility. I actually often will get an X-ray even the next day to see how much contrast has been retained. Tells you a little bit about how severe is the constipation. I really like the image on the contrast study of evacuation film. It tells me, does the patient's colon have the capacity to empty, or does the contrast retain? For how strong will it need to be if I ultimately do a rectal enema or an antegrade enema? You make a good point about continence. I started off by talking about the different mechanisms whereby we achieve continence, and the topic today was on constipation. And all of those patients have a full capacity to have voluntary bowel movements. These are absolutely continent patients, but they are potentially soiling because they have overflow constipation. And that's the accidents are on the grounds of having a colon that is too full with rectal impaction. There's a whole group of continents that they can't help. Then because they have a poor spinal innervation of the rectum. Or, for example, that is the spina bifida group, or any spinal anomalies, or presacral mass, or anorectal malformation patients who have poor development of their sphincters. Those are patients that have true incontinence, and for them, they need a mechanical system. They do not have the capacity to successfully control their bowels from an anatomic point of view. I just want to get to a couple of the chat questions. Someone wrote about senna and bicicotal availability. I know that sometimes senna in some countries is not available. I'm not exactly sure why. They should be available, but if it's not, almost always I've heard bicicotal is available. Someone's writing here, is there a danger of overuse of suppositories and enemas in these patients? Absolutely not. There's no danger at all. I don't see any reason why that could be in any way dangerous. It does not limit the child's ability in the future to have successful voluntary bowel movements. So is there any role, someone writes, for stool softeners? Absolutely. I mentioned that. Stool softeners in the easier patient. I wonder if we can go to change my view. I'd love to see their gallery view. Stool softener in the easier to treat patient works great, but you just have to recognize that if that's not working, then you need to go to something a little more strong. And the more strong is the stimulant laxative, like we talked about, senna and bicicotal. Someone writes, if you don't have manometry, how can you diagnose if there's a sphincter problem? That's a really, really important question. Anorectal manometry, I think you need to figure out a way to make that available. It's a very thin probe with the machine and fairly easy to you don't have anorectal manometry to objectively prove that, well, in that case, my advice would be to give an empiric Botox injection and see if that makes a lot of difference for the family. And then essentially you have made the diagnosis of a sphincter problem without confirming it manometrically, but your treatment obviously worked. Someone asked actually about the details of Botox, and Botox, I give 100 units mixed in 1 to 2 cc's of saline, injected directly into the anal canal, into the mucosa. I don't want to give it into the anal skin, and in all the way around the circle in 8 positions. Okay, someone wrote, well, we talked about that there are alternatives to evaluating colonic motility. We use colonic manometry here, but if you don't have that available to you, you can do a SITSMARC study, which is very easy. They swallow the little beads and you get an x-ray 4 days later. And your nuclear medicine colleagues may be able to help you with a scintigraphy study. And if anyone is interested in that, just please send me an email and I will give you the protocol for nuclear scintigraphy. You already have a nuclear medicine department doing your renal studies. They can do a colonic study for you as well. And I'm going to put my email here in the chat. So you have that. And the other thing you might like is some videos. And a whole series of our videos are now in the chat at this website, expertsinsurgery.com. And then I strongly recommend you get the app stay current. And there's a whole colorectal section, which includes podcasts and a whole bunch of things, which I've really been very excited and have had a lot of fun adding to. It's a great app and a great resource. And I almost use it like I would a Facebook, where you sort of flip through what are the offerings in colorectal today. A lot of our material is there, and there are many colleagues from around the world that have contributed to that. So someone wrote here, hold on one second. I'm trying to keep up with all these questions. Patients, GTN cream. I don't know what that is. Do you mean, what is GTN cream? Some
Nitroglycerin. Nitroglycerin.
Oh, nitroglycerin for the anal canal. You know, nitroglycerin won't work nearly as well, but there is something called diltiazem cream, which is a calcium channel blocker, which works a lot like Botox and obviously does not require an anesthetic. So we've used that too in certain patients. Botox is a little more powerful and more definitive, but diltiazem cream is a very good option. How long does it take to assess bowel management program effectiveness? Well, we do it fairly quickly in a 1-week program, and you should get really good results. And then the question is, can you sustain those results? And how do you sustain those results? Good communication with the family and the patient, and an occasional X-ray to confirm that what you are trying to achieve is succeeding. Are you successfully emptying the colon is the main question. What's the best age for doing surgical correction in HSD? Is that Hirschsprung's disease, HSD, I'm assuming? Is that Dr. Mohammed Nasser? What is the best age for doing surgical correction in HSD? Do you mean Hirschsprung's? Well, let me answer that. I almost always do Hirschsprung's operations in the newborn period when the diagnosis is made. Some surgeons do some irrigations and wait a couple of months, not my personal preference, but I am okay with that. Occasionally, quite rarely, the patient is older and is diagnosed at closer to age 2 or 4 or even 7 I've seen. I saw once a patient that was 22, and then you do the operation when you have the patient in front of you. Someone's asking about a disimpaction protocol. Well, I mentioned that I would use a Miralax prep, just like you would for a colonoscopy. For those of us who have reached the age of 50 or more, perhaps you have experienced, like me, a colonoscopy and a bowel prep. That works really, really well, a Miralax prep. If you have an impacted rectum, we would give enemas. And obviously, if you can't unimpact the patient or disimpact the patient, you may need to go to the operating room and do a manual disimpaction. Of course, that happens from time to time. Timing to offer a Malone. Well, I like a Malone a lot, and I use it as a bridge to ultimately getting the patient to have their own bowel movements. So I would say you offer Malone at the time where you need a regularly emptying colon, a regular bowel movement, and you need the child clean and in normal underwear. So most of our Malones are going in somewhere between age 4 and 12. So any patient who is having problems with fecal incontinence for the reasons that I stated of true fecal incontinence, or any patient who's having the inability to empty their colon due to a motility reason, which was the subject of today's talk, a Malone is a great option for those patients. One really nice thing is that the Malone almost always works, even in the face of colonic dysmotility, even in the face of segmental dysmotility. For the patient with a problematic sigmoid, greater than 80% of those patients get better with a Malone only. I would consider a Malone a new form of medical management. I would say that it's as important to the management of these patients as a G-tube is to the management of a patient with poor nutrition who cannot provide adequate oral intake. It's simply a route. It's access to the colon for an enema, but this particular enema is given antegrade, which is a little bit more effective than retrograde. Looks like I'm caught up with the questions. What else? Shani, what else did we not cover?
Yeah.
Oh,
So
Kathleen Cooper.
yeah.
Hold on, Kathleen Cooper gives me a three-parter. By the way, it's a lot easier to manage a three-parter with a text box than it is standing at a podium. So thank you for that. In the Bahamas, we have neither manometry or nuclear medicine. So constipation is a vexing problem. Well, you certainly could do a sitz mark study. You could have them swallow the beads and get an x-ray 4 days later and see where they are. Nuclear medicine, you have no nuclear medicine at all. You cannot do renal scans or things like that. If you could, then those folks who know about nuclear medicine can do a scintigraphy study for you, and I'm happy to send you that protocol. How do you handle tolerance to laxatives? Well, Kathleen, I really don't believe that exists. I think the patients take laxatives, you give them the appropriate amount of laxatives, you give them the dose that they need to empty their colon, and they don't seem to develop a tolerance. I think that's a bit of a myth. If they don't tolerate the laxatives and the dose they need is quite high, then you might want to consider rectal or antegrade enemas. And your point about Botox, we all know that Botox is a temporary fix. Is this offered indefinitely? Interestingly, if you give Botox, the patients in almost all circumstances tend to figure out how to properly relax their sphincters, and they don't need continued Botox. Almost all patients need just one. The occasional patient needs two, and the rare patient needs 3 or 4 Botoxes. This should be connected to, for the properly aged and mature patient, biofeedback, sort of learning how to relax their pelvis. Is Hirschsprung's a continuum similar to attenuated FAP? Yes. Hirschsprung's is a fascinating disease with a very broad phenotype. The vast majority present with dramatic symptoms, distension or enterocolitis in the early parts of their life. Under a year of age, 90% are diagnosed. But there are definitely some outliers, and that is the older child Hirschsprung's, which you can rule out with a rectal biopsy. Of course, if you have anorectal manometry, you can rule that out. If they have a rare rectoanal inhibitory reflex, then they don't have Hirschsprung's disease.
Mark, I have a question. I have a question from one of the general surgeons, recently retired. His question is, anorectal malformations, how are they managed in a low income setting? I'm not sure of the question, but you could answer it.
Well, I think, obviously their anorectal malformations is an extremely common congenital problem, and they're managed the same. They get a colostomy, they get an anal repair and a colostomy closure. The challenge, I don't believe, is the anatomic correction. The anatomic correction, of course, needs to be elegant, and you need proper training and confidence in doing that procedure. One of the problems with anorectal malformations is you can do a proper anatomic repair, but you don't get a clean patient. And that's when strategies such as bowel management come into play so importantly. So someone's writing here about, or Kathleen again, about melanosis coli. Melanosis coli is with long-standing senna and has never been shown to be a problem other than changing the color when you do a colonoscopy. So I am not worried about that at all. Kathleen, if you email me, I can send you a PDF of an article we wrote demonstrating the safety of senna, incredibly safe in hundreds of patients.
Hi, Mark. So since I've been back, we've done about 15 anorectals. And just as you said, the issue is some of them are, we have archipelago. So some are in Freeport, and the follow-up has been difficult, especially with COVID. But from doing the cases, myself and recently retired Dr. Loxley Monroe, we have had no issues, operating on those patients.
Shani, I'm going to send you the nuclear medicine protocol and the senna article. It seems like those were some common questions.
Yes.
And then you can perhaps share that with the group.
Okay.
And I also would very much invite you all to email me at any time with any difficult patient. I'd be happy to help you. or any of your successes. If this talk promotes someone diagnosing a child with a sphincter dysfunction that you might not have thought about, I would love to hear about that success.
I'm just going to scour the chat. Okay, Corinne Sinqui, she's a pediatric hematologist. She said, we had nuclear medicine Bahamas for over 20 years, suspended since COVID pandemic due to logistics. We are preparing to resume it, but don't recall ever getting a request for assessment on constipation.
Well, I'm going to send to Shani the protocol. It's actually quite easy. If you have nuclear medicine capacity for your renal scans, it's a very helpful way to assess the colon. As I said, the cheaper way is just to have the patient swallow the beads and get an X-ray a few days later and see where the beads are. And if they're all collecting in the sigmoid, then you know that there's segmental sigmoid disease. If all the beads are gone, then obviously that constipation is not so severe. It's just sort of an objective way of testing the amount of dysmotility.
Yeah, we've done a few of those, myself and Dr. Marcus Cooper. He's an adult gastroenterologist, but he has some experience with kids, and we have done a few of those.
All right, listen, I'd love to join again. If there is a topic of interest, please let me know. We look forward to certainly visiting the Bahamas one day soon. I asked the members of my team if anyone wanted to go to you to hear the presentation, and we had lots of volunteers to be on your side of the water, listening to the presentation. So we would welcome that. And I hope we put this pandemic behind us so we can get together in real person time once again soon.
Right. So Mark, you could tell them what we're working on in the background if you want to, just to let everyone know that you're going to be here soon, hopefully.
Yes, well, we're very excited about the prospect of helping to take care of patients in your region and making sure they get the best level of care with any expertise that we can offer, and our opportunities to learn from you all. I know there are a lot of patients in your part of the world spread across a number of islands, so logistics makes things more difficult, but we are here for you. We want to be partners, and I think if anything that the pandemic showed us is that the actually world is, from a communication point of view, is pretty small, and we can connect a lot easier now that we've all become experts with this kind of communication. So please don't be strangers. Keep the communication lines open.
Okay, Mark. Well, thanks for an excellent presentation. And as you know, you'll hear from me emailing you probably every other day.
All right. Great to see you all. Have a nice day. Thank you. Amala, thank you very much.
Yes,
for organizing.
thank you, Dr. Levitt. But before you leave, can you repeat your email again for us, please?
Sure. I put it in the chat, but it's mlevitt, M-L-E-V as in Victor, I-T-T, at childrensnational.org. And Ashani can share that with you. And I am going to send him the nuclear medicine protocol and the SENA safety article. And if any of the other areas are of interest to you, just email me and I can give you that PDF, or depends on what people were interested in. Those seem to be the two that people needed as a reference.
Yes, and there was also a question if you could repeat the colorectal websites that you had mentioned.
Yeah, well, there's a whole bunch of videos available at www.expertsinsurgery.com, all one long word, expertsinsurgery.com. And the other reference that I strongly recommend is Stay Current. It's an app, Stay Current. One word, mushed together, Stay Current. All of the podcasts are there. You might like them. And
well, thank you very, very much. Did you have any final words, Dr. Levitt?
I was just going to say there's a very good podcast on this very topic with some gastroenterologists that joined that call that people might enjoy. No final words other than thank you so much for having me, and I hope we can be in person soon.
Thank you very, very much. It was a pleasure to have you, and for that excellent presentation, as echoed many times in the chat. So have a great
Okay.
day, and thank you for joining us. And thank you to Dr. Shani Knowles for making it all possible and setting up the connection.
Thank you. Have a
Okay.
good day and a good weekend, everyone.
Thank you. And before we leave, just to remind everyone, our next CME will be on Wednesday, the 10th of November, and we will have one of our very own, Dr. K. Joy Sims, a pediatric nephrologist, joining us. So we look forward to seeing you then. And a very special thank you to Dr. Halliday, our technical support crew, all by himself. We really appreciate him, as we know he's spent most of his week arranging and managing our very successful research day. All our presentations are available on the YouTube link that we have put in the chat, so feel free to peruse them in your own time. Thanks again, everyone, for joining, and have a great day to the rest of the world, because the world seemed to have joined us this morning. Happy day, everyone.